like vasopressin and oxytocin. Not to mention the silence all phones. So, it's fine, Ma, you're okay. So the anterior pituitary then communicates to the ovary. And you also have to remember here that the ovary communicates to the endometrium, or the uterus. What you have to remember here is that the uterus really is just an innocent bystander, right? The uterus just does what it's told. We can, if it's the ovary telling it what to do, or like in frozen embryo transfer cycles, we can give people pills, we can put patches, we can give them shots. We don't need the ovary in the brain. We just need hormones. Whether it comes endogenous or exogenous, we can control the uterus and tell it what we want it to do. So remember that in this process. So as you can see there, the hypothalamus releases GnRH, and that's going to be important in a second when we start talking about things like Lupron, right? Because Lupron is a GnRH analog. The anterior pituitary then releases either FSH, or it can also release LH based on what GnRH pulse is telling it what to do. The FSH then tells the ovary. What does FSH stand for? Does anyone know? What does it do? What's its main function? Stimulates follicles. No trick questions here. So what it's going to do is it's going to stimulate that ovary to make follicles. So let's talk about the menstrual cycle in terms of days. Early in your menstrual cycle, days 1 through 5, what's happening? Well, is estrogen level high or low?
Low.
Pretty low, right? That's why we do a cycle day 3 ultrasound. Estrogen should be low. FSH should be trustable. You should be able to know whether or not FSH is a readable value. When FSH, right? When FSH comes down to the level of the ovary, what does it do? Remember, this is early in the cycle. You've got all of these follicles that are just sitting there waiting. Those are called antral follicles. And those antral follicles have actually been waiting their turn for about 8 months. Right? There's been about 8 months of development in their own turnstile in the ovary to become the antral follicular pool. Now, out of that antral follicle pool, in a normal menstrual cycle, you have FSH go up. That FSH helps this pool figure out who's going to be the one dominant follicle. Right? That's why humans, we have monofollicular response. Other species, they have polyfollicular responses, and that's why they can have more than one in a litter, per se. So we have monofollicular response. Once that dominant follicle is chosen by day 6, 7, 8, that dominant follicle starts to send off killers. It says, all right, everybody else, go away. You're done. Right? So the rest of those antral follicles, they don't get recycled. They go away. That dominant follicle, under the auspices of FSH, start to grow, grow, grow. And as you can see, FSH in about day 7 to day 9 of the menstrual cycle. Come on in. Come on in. Yeah, of course. So between day 7 and 9 of that menstrual cycle, that dominant follicle has been chosen. It's growing. Everybody else has gone away. And what is it starting to make? What hormone? What are we monitoring going up? E2. Love it. Guy in the back. He runs all the labs. So once this dominant follicle is getting bigger, 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 it's starting to make estrogen. And I told you, the uterus doesn't know what to do until it's told. So that estrogen from the ovary, from that dominant follicle, goes down to the level of the uterus. And what does it tell the uterus to do? What does it tell that endometrial lining to do?
Thicken.
Ooh, get thicker. Hence the proliferative phase. You see how everything is supposed to be going according to plan here. So the brain tells that ovary, start making that follicle. Once we get that follicle to start going, it's then out of the brain's hands. The follicle does the rest, right? We can see that in our cycles. They become FSH independent. Once you get that train moving, it's going to be hard to stop it. So as that follicle is getting bigger and bigger and bigger, look at your estradiol level. Right? E2 in this green, look what it's doing. It's going up, 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 up. And as that estradiol level is going up, and that estrogen, remember, is coming from that dominant follicle, the uterus is getting thicker. That estrogen then does what? Feeds back to the level of the hypothalamus. and it is a positive feedback to the hypothalamus to change the way that GnRH tells the anterior pituitary. Instead of releasing FSH, what does it do in the middle of the cycle? LH, right? So here's your FSH, here's your LH, LH surge, right? You get that LH surge. Now what does LH do at the level of the ovary? Simple answer. Causes it to ovulate, right? That's the simple answer, but it does three things actually. The first thing it does is it will go down to the level of the ovary and it reinitiates the meiotic process at the level of the oocyte. My folks in IVF Center, when we look at the report, grade 1, grade 2, grade 3, M1s, M2s, GVs, at this stage of the game, it's still a GV or an M1, a grade 1 oocyte, and you cannot fertilize grade 1 oocytes. Those are immature oocytes. So the first thing LH does is it reinitiates that meiotic process. It starts meiosis 1 back to meiosis 2, so that that egg has one copy of chromosomes. Remember, it kicks out that polar body, and that's how we know it's a mature egg. When those embryologists look under and they go to ICSI it, it has to be mature. Now, how long ballpark do we think it takes to go from M1 to M2? How long do we wait between trigger and retrieval?
36 hours.
Bingo. That's why we do it, right? Because when you get that LH surge, and now for my clinical people, think about the way that we do our HCG triggers. We do our HCG triggers and we say, let's do the trigger and then IUI either 24 or 36 hours later. Because we want to make sure that that sperm is there when they're ovulating that mature egg. If we're going to err, let's err on the side of early than late. Right? You're fertile up about 12 hours before you ovulate. You're only fertile about an hour after you ovulate. So err on the side of before you ovulate. So for the IVF folks, we get that LH surge and trigger, and we're going to talk about the different types of triggers in just a minute, but in general, when we trigger or when you have a surge in your regular menstrual cycle, it starts that meiosis process to make a mature egg. The second thing that it does is it starts the pro-inflammatory cascade that's required to make this thing rupture. It's a violent event that happens in your body every month. This egg literally busts out of the follicle, blood into the belly, egg into the fallopian tube, right? So let's leave the egg in the fallopian tube for a minute. Now that this egg is out of that fallopian tube, you still have this LH there, and that LH will continue to stimulate the cells that were making estrogen to now make something called the corpus luteum, where that follicle ruptured from. And what does that corpus luteum start to make? Progesterone, right? So now we've gone from a very estrogen-dominant milieu, right, in the green here, in the first half of the cycle, to whoop, here comes our progesterone, that purple thing. So after ovulation, progesterone, the most important thing that progesterone does is after ovulation, it goes down to the level of the endometrium that has been primed by estrogen. It's been thickened and primed by estrogen in the first half of that cycle. The progesterone, whether it's from the follicle or from progesterone that we're giving, it will then take that endometrium and convert this proliferative endometrium to a secretory endometrium, and that lining at the very first lining of that secretory endometrium is called the decidua. That decidua consists of multiple different things that are required for implantation. So they have structural molecules like integrins, selectins, kind of like a lock and key. If an embryo rolls around on that decidua and finds the key to its lock, it binds, it sticks, and those signals help the trophoblast cells in that blastocyst, in that embryo, know where to start to invade. That decidua also has certain maternal immune cells, natural killer cells, regulatory T cells, that are required to be chaperones to those trophoblast cells. So the conversion of this proliferative estrogen-primed endometrium to a secretory decidua is vital to successful implantation, right? So that is where our ERA, for instance, why do we do an ERA? Because there is this window opens for a very short period of time called the window of implantation, and then shuts, right? And for most people, it's around 120 hours of progesterone exposure. For others, it's shorter. For some, it's longer, right? So that's why it's important to kind of know where that window of implantation lies. All right. So remember, we've got progesterone, we've got this corpus luteum, we have this egg in the fallopian tube. So now that egg in the fallopian tube, so let me draw out, forgot to give progesterone its due. So progesterone, we have this egg in the fallopian tube. And if we get fertilization, if sperm meets up with that egg, what's the first hormone that embryo starts to make? HCG, human chorionic gonadotropin. And aside from being able to walk into the bathroom and pee on the stick and tell everybody, hey, we're pregnant, what is the main focus of HCG? What is the main physiological function of HCG?
To keep the corpus luteum
going.
To keep that going. Why?
Produce progesterone.
Because it needs progesterone, progestational hormone, right? That's the term, progestational hormone. Because guess what? What happens if you don't get a pregnancy? You don't get HCG, you don't get rescue of that corpus luteum, and then by default, every corpus luteum that you make in the ovary, by default, it is designed to involute, go away, hence the progesterone goes away, and then what happens then? Menses. You get a withdrawal bleed, right? So it's not the fact that you start progesterone on someone that they have a menses. It's the fact that you stopped it. It's the fact that it went away. Okay? Good. So this is a highly orchestrated system between the brain, the ovary, and the uterus. And if anything goes awry there, we have to know how to fix it. So do you guys, is that a little bit more clear on how the brain talks to the ovary goes through, the egg is in control for much of the time. The follicle where the egg is growing up in is in control. It uses hormones to tell the brain what to send. It also uses hormones to tell the endometrium what to do. Makes sense? Clear as mud, eh?
Yep.
All right, good. Any questions about that? Good. You're either lost or you're following along very well.
I do have a question.
Excellent.
Okay, so when we do the ERA biopsy,
Yeah.
why is it that, okay, so let's face it, every cycle can be different in a woman. Okay, maybe some cycles her endometrium's thicker than other cycles. So if I time my endometrium biopsy and I get that perfect 120 hours of progesterone, why do I assume that it's going to be the same in the next cycle when I do the transfer cycle?
That's been one of the biggest critiques of the ERA since Carlos Simone came out with it in the early 2000s, right? That was one of the biggest critiques. There have been some pretty decent studies showing that, you know, for the closer you are to your ERA, the better chances that you're still within that window of receptivity from that ERA. So I won't go any farther than 3 to 6 months from the ERA. I repeat it if we have.
Okay.
I'm with you. I mean, there's a little bit of skepticism there with some of the issues, but I personally have been very successful with the subsequent cycle after the ERA.
Okay.
Yeah. I personally haven't been pregnant, but I personally get pregnancies from that.
Oh, you got another question?
Yes.
Do you think the success is due to the hours of progesterone exactly, or do you think that the actual performance of the biopsy, that fresh tissue,
Almost like
that
a scratch,
has something to do with it as well?
I think it's probably a little bit of both, but in individuals who the window of receptivity is shifted, I think it's more of the phase of implantation than it is the scratch. I think in some the scratch is definitely beneficial. So I mean, there are some believers that they scratch everyone. Right?
Mm-hmm.
Decent studies that have come out that say, look, man, you don't need to be doing that. Decent studies to show that you don't need to do an ERA biopsy on everybody. And just to clarify, an ERA biopsy for you guys is it's an endometrial biopsy that we do in a mock cycle. We send that tissue off and it tells you, yes, put the embryo back at 120 hours of progesterone exposure, or yes, put it back at 144 or 96, and then we can time when we do our frozen embryo transfer based on progesterone exposure time. Yeah. Good question. All right. Cool with that. You gotta understand how this works in order to start talking about some drugs. Awesome. You can always go back. All right, so take home points. I am one of those people, I'm gonna tell you what I'm gonna tell you, and then I'm gonna tell you what I told you, right? So, physiology take home points here. GnRH from that hypothalamus will, and guys, you're more than welcome to have these slides, right? So if you want the slides, you can, I can email it to you. GnRH stimulates FSH and or LH release based on where we are in the menstrual cycle. Early in the cycle, what do we need to do? Make a damn follicle, right? So FSH is going to be the dominant form that's coming from the anterior pituitary. Estrogen from the ovary, from that developing follicle or oocyte, stabilizes and builds up or proliferates the endometrium in that first half of the menstrual cycle. LH, once the estrogen's high enough, our follicle's big enough, the brain senses that, LH is sent from the anterior pituitary. LH initiates ovulation. After ovulation, progesterone from the corpus luteum stops growth and induces maturation changes in the endometrium. So, this is important here in our PCOS patients, in our anovulatory, in our hypo patients. No ovulation means no progesterone, which means no menses. Right? So that's why patients that have issues with ovulation, they just don't get a period. We can give them a fake period by giving them what?
Progesterone.
Progesterone, yeah. So no pregnancy, you get the corpus luteum involuting, you get progesterone withdrawal, you then get menses. If you get pregnancy, that embryo, even while it's rolling around in the fallopian tube and then ultimately sitting down in the endometrium, starts to make HCG, rescues that corpus luteum, progesterone production continues, that's why you don't get menses. Right? So your progesterone continues. Remember, it's not the fact that you took progesterone that you get a period, it's the fact that it goes away. It's that withdrawal. All right, good. Questions about that? Oh, good. Good time. 20 minutes on that. All right, so very quickly, I just want you to know what all the medications are. And then we're going to go through in this, and we're going to talk a little bit about where do these guys impact, right? Clomid, so remember, Clomid or tamoxifen, I'm going to talk like they're one and the same. They're both selective estrogen receptor modulators, meaning that in some tissue, they're going to act like an agonist. Bind the receptor, make things go. In other tissues, they're going to act like an antagonist. Bind the receptor, make nothing go. Right? So that's the difference between agonist and antagonist. So clomiphene, it's a serum. We usually give it cycle day 3 through 7. It blocks estrogen negative feedback at the hypothalamus. So what it makes the brain think is, ooh, man, there's not much estrogen around here. Right? So what is the brain going to do if it senses low estrogen?
Increase
Send
FSH.
the signal through GnRH to the anterior pituitary to tell that anterior pituitary, hey dude, we're pretty low on estrogen. What's the best way to make estrogen? Make a follicle, right? Make a follicle. Those granulosa cells in the level of the ovary will start to make your estrogen will go up. So that's what happens, right? So you give Clomid, it tricks the brain. It binds those estrogen receptors at the level of the hypothalamus and the anterior pituitary. It tricks the brain into thinking that, whoop, estrogen levels are real low. So then the brain pumps out more FSH, and that's why in an anovulatory, meaning no ovulation, like a PCOS patient, you can get a PCOS patient to ovulate with Clomid. That's also why in an individual who's ovulating totally normally, in our unexplained population, we can get them to ovulate 2 or 3, sometimes 4, just with Clomid, right? Because it tricks the brain into thinking that we need more FSH to make more estrogen. Because if we get more FSH, we're going to get more follicles. It's just like if we were to take a pin of FSH and just drive it into somebody's butt, right? Now we're doing this endogenously. Good. Now, the only downside of Clomid is that in many women, it can actually cause thin endometrium, because I told you, in some tissues, it tells it, yep, go ahead and work. In other tissue, it kind of blocks the effects of estrogen. So it binds at the level of the endometrium, it can block that proliferation of the endometrium, and you get a thin endometrium. So not great. So that's why we monitor the endometrial thickening at the level when we're doing a Clomid cycle. Same with tamoxifen. Now the big difference between tamoxifen and Clomid, does the same thing at the level of the brain. Tamoxifen at the level of the breast. That's why it's a famous serum. We use it for breast cancer survivors because it blocks estrogen receptor at the level of the breast tissue. At the level of the endometrium, they're the opposite. Clomid and tamoxifen are opposite. Tamoxifen will actually cause the endometrium to get a little bit thicker. So if I see a patient that I like the way that the brain reacts to Clomid, and I like the way that the ovaries react to Clomid, but the endometrium is very thin, I'll switch to tamoxifen, because tamoxifen won't make the endometrium as thin. Got it? Let's switch to letrozole. Letrozole is another medication that we use pretty frequently in the clinic to do oral ovulation. Letrozole, a brand name Femara. The way that that works is it's called an aromatase inhibitor. And at the level of the ovary, there's two different types of cells. Right? There's the theca cell, and then there's the granulosa cell. The theca cell is very much an androgen-dependent cell. LH goes to that theca cell, takes cholesterol, converts cholesterol all the way down to androstenedione. Androstenedione is then converted to testosterone. Now, in the granulosa cell, testosterone is then converted to estrogen. So that's where your estrogen is coming from, is that granulosa cell. The enzyme that converts testosterone to estrogen is called aromatase, right? Way down here, aromatase. So if early in the menstrual cycle we give you an aromatase inhibitor, we're gonna block the production of estrogen. So what's that gonna do to the level of estrogen in the blood? It's gonna make it really low. What's the brain gonna think about that? It's not gonna love that, right? It's not gonna love that. So then the brain says, shit, pretty low on estrogen. How are we gonna get estrogen levels up? Hypothalamus is going to tell GnR, is going to send GnRH to the level of the anterior pituitary. The anterior pituitary is then going to send follicle stimulating hormone to make a follicle, and then we're going to start cranking. That's when you're going to be able to get a follicle, and that's how your estrogen levels go back up.
So, I'm sorry. How long would they be on the letrozole?
5 days.
5 days.
Cycle day 3 through 7, same thing.
Okay.
Yeah, 5 days. Because you want it to go back up. You want it to rebound, right? So we're using these two medications. They do the same thing on the back end. They just do it by two different mechanisms, right? So on the back end, they cause the brain to release more FSH than it would have without it. On the front end, they do it by two different mechanisms. Clomid and tamoxifen are tricksters. They trick the brain into thinking that estrogen is low. Letrozole actually makes estrogen levels very low, but both of them do the same thing by increasing FSH. Now, a little bit of data, 2014 New England Journal of Medicine, large randomized controlled trial comparing Clomid and letrozole in anovulatory patients, PCOS patients. Pretty clear that Femara or letrozole better in PCOS patients than Clomid. Now, if I have an unexplained infertility patient that shows up into our office, I do like letrozole. I like letrozole in all comers. The only time I'll use Clomid first is if they come in and they say, hey, my last pregnancy I got pregnant on Clomid. I'd be a fool not to start with Clomid, right? You don't want to be that doc that says, no, I've got a better med for you, right? It's like, how can it be better? Dude, I got pregnant, right? So that's the use of Clomid and Femara. You can flip back and forth. Nowadays, letrozole has taken a little bit more of the forefront. Just because I think the side effect profile is a little bit better. The half-life is shorter. It doesn't bang the ovaries that much, and you don't have as many residual cysts as you could with Clomid and additive effects of Clomid. So those are our two oral medications that we use a lot. Now, for my IVF folks, you guys use letrozole when?
After retrieval.
After it's just stopped.
On the back end, right? I don't. I've never used letrozole on the back end of a cycle. I've only seen it here. Theoretically, what it does is it stops the production of estrogen and it reduces estrogen levels, right? I think patients do pretty well with that. I haven't had any severes. I haven't had any severes, right? So I mean, that's all the goal. Maybe a couple here and there. All right, so big players here for injectable meds. And then we're going to talk about them specifically in each cycle and how they work. So, big player here, follicle stimulating hormone, or FSH, right? We talked a little bit about it in the endogenous system. It comes from the anterior pituitary. Exogenously, we can get in a couple different forms. The first is recombinant FSH. Does anybody know what recombinant means? It's okay. It's where we took a human gene that encodes for follicle stimulating hormone. We put it into either a viral or a bacterial vector. We then take that vector, transfect it into Chinese hamster ovarian cell line, and we make those cell lines produce this hormone, human hormone. It's then purified, calibrated, and put into a pen for usage at your favorite fertility center. Right? So that's recombinant. The big two that we use are Follistim and Gonal-F. Comes in units, comes in pens, right? The other medication that you'll use is a urinary-derived FSH, and that's Menopur. So recombinant, Follistim and Gonal-F, urinary-derived Menopur. The difference between the upper two and Menopur is that Menopur will actually have a little bit of low-dose HCG. Now, I want you to think about this for a minute. I'm going to erase this. Is everybody okay if I erase this?
Yeah.
All right. So, this is going to make a lot more sense once we talk about it. HCG, TSH, LH, and FSH. They're all what we call heterodimers. Heterodimers meaning that structurally, when you look at the tertiary structure, three-dimensional structure of those hormones, they have an alpha chain and a beta chain, right? These guys, their alpha chains are all identical. So, Jason, when we do an assay for HCG, what are we looking for? What are we testing for? What specific epitope or specific chain of HCG?
Beta chain.
Beta. Why?
Because of the alpha chain is the same.
Because, dude, if you went looking for the alpha chain, you'd have a hot mess, right? Because you'd get everything from TSH, FSH, LH, HCG. So when we say, hey, check a beta, it's a beta HCG. The reason why we're going after beta is because it's unique to HCG. Now, the catch here is that, yes, the alphas are all identical, but LH and beta and HCG, their beta chains are almost identical, right? So why is that important physiologically? Because now, if their alphas are identical and their betas are ridiculously similar, shoot, we might be able to use HCG as a mimicker of LH. And why is that important? Well, because it's all about the half-life, right? The plasma and the biological half-life. The half-life of LH is measured in hours, right? So unstable, you give somebody a shot of LH, it's going to be gone in a matter of hours. So half-life is hours. HCG, half-life is days, right? It does not get metabolized as quickly. We're going to talk about, most of the time, that's a pro for HCG. It's stable, it's cheap, it works like LH. We can use it as a trigger. There's only one scenario, maybe two scenarios, where you wouldn't want the half-life of HCG to be banging those ovaries around for days and days and days, and that's when?
Hyperstimulated?
Exactly. It's when you are at risk for ovarian hyperstimulation syndrome. You want your trigger to get in like SWAT team, do its job, and get out, right? HCG, though, will stick around, will bang up those ovaries, and that's why patients can get really, really sick with a high level of HCG trigger, because it sticks around and just sticks around and sticks around. Now, with ovarian stimulations like letrozole, Clomid, tamoxifen, even low-dose FSH, those guys, you can give them HCG to the cusp. Their ovaries are not that stimulated. Even if the HCG sits there and bangs their ovary for the next couple of days after it ovulates, you're not going to be overstimulated. Now, some on Clomid and some with those injections, they'll call and say, oh my God, I feel terrible. It feels like my ovary's going to explode. Well, pretty much did. All right? Finally, again, 4 times. So that's the difference. That's why we can use HCG to mimic that LH surge. And we'll see in just a minute when we start talking about the different areas of each cycle that we run, the IVF cycles. So medications to induce a surge, HCG, and then leuprolide, acetate, Lupron. So, probably shouldn't erase all that, but I can draw it again. HCG is that act at the level of the brain or the level of the ovary? Ovary, right, ovary, because it's pretending like it's already been released from the anterior pituitary. It just goes straight for the oocyte. Lupron is a GnRH agonist. Remember from that diagram, where does GnRH act? Hypothalamus, anterior pituitary, or ovary? Anterior pituitary, right? So a GnRH is released from the hypothalamus. It goes to the anterior pituitary, and it tells it FSH or LH. When we give Lupron, which is a GnRH agonist, when we give a single dose as a trigger, it is a physiological GnRH boost to the anterior pituitary that then floods with LH. A little bit of FSH, but mostly LH. So what Lupron trigger will do is it will induce an endogenous LH surge. That's why I like the dual trigger. I like to have best of both worlds. I think that an endogenous LH surge is nothing better than a patient's hormones to do the job that we want them to do. So I'll do that Lupron trigger to get the endogenous system to work, but I'll also give a little low dose of HCG as a little safety net, right? Whatever LH doesn't do, HCG will go in and mop up the rest.
It seems like when you're doing the Lupron with the HCG, there's less chance of them going into hyperstem.
Why?
I don't know, I'm gonna ask you that question.
Great, because Avidrel, right, so let's go back up a step. Couple doses, couple different ways that we can give HCG. One is Avidrel. It's recombinant, meaning that we took the human gene, put it into those Chinese hamster cell lines, purified it, bang, you take one shot that's already been made. The second way is with either Pregnil or Novaril. It just depends on who makes it. Merck makes one, EMD Serum makes the other one. Whoever gets it to us the cheapest, that's what I'm happy to use. They'll come in 5 or 10,000 doses, 5 or 10,000. 5 years ago, we used to say, yep, 10,000. Take a 10,000 HCG. How sick did they get? Pretty damn sick. And we said, wait a minute, a little bit dangerous. How about we back it down a little bit and go 5,000? Better, but still, with the 3333s with 5,000, you can still get a pretty bad case of OHSS. Right? Rarely do you get those severe and criticals where you have to admit IV fluids, ICU, clot burden patients. But 5,000 still can cause a patient to feel pretty cruddy. With the dual trigger, you give Lupron, it causes that endogenous LH surge, and what kind of doses are we giving of HCG?
2,500.
2,500 is the typical dual trigger, but it's somebody with an E2 above 3,500 with 25 eggs or more, you'll see me go 1,000, you'll see me go none, right? Because really the biggest thing about HCG, why do we really want to give HCG as a trigger in an IVF cycle? That's because HCG not only is good for ovulation, it goes down to the level of the endometrium, starts to initiate that decidualization process. It's good for implantation, but it also helps keep those corpus lutea alive after you do your retrieval. And if you have good corpus lutea, what are you going to have? Good progesterone, right? Now we supplement with various forms of progesterone, but the patient's progesterone is going to be better than any progesterone that I can give them. So HCG does have better pregnancy rates in fresh transfers. But if I'm not doing a fresh transfer, either because of PGT, or because of risk of OHSS, or because I don't like what the endometrium looks like, why am I giving them any HCG to begin with? Right? Most donor egg banks only use Lupron triggers. Now, there's a little bit of bad data a decade ago that LH triggers or Lupron triggers don't cause great maturation rates, or the pregnancy rates, even in a frozen embryo transfer, are lower. That data has been debunked. Right? I do plenty Lupron triggers for patient safety. The patients ultimately later on get very much pregnant. Right? So, all right. So those are the triggers that we use, or to induce a surge, even in the clinic when we're doing our OIs, our oral ovulation induction cycles. It wasn't but 2 or 3 years ago, we were like 10,000, 10,000, 10,000. Now everything is 5,000, 5,000, 5,000, because you don't need that much. All right, there's one little algorithm, I think it's 83 units per unit of BMI for the patient is what you need to get optimal maturation. Because remember, that's the whole reason. We want to start this process of ovulation, but we also want oocyte maturation.
Is that the dose that y'all are ordering for the patients, is the 5,000?
I think
Usually,
that,
yes.
I want to say yes. I think that at one point, the 10,000 was like $99 and the 5,000 was $129. You do the math, I don't know why. So we were just getting 10,000, 10,000, 10,000. So then the IVF nurses have to be real careful. Hey, which one do you have? Well, Huber wants 2,500. So if you have a 10,000, you need to put 4 cc's in, pull one up, bang. You have a 5,000, you put 2 cc's in, pull one up, bang. You know, when we were flipping back and forth, there were a couple times where we had people getting more than their allotted HCG. Which, look, if their estradiol levels 2,000, 2,500 or below, not a big deal. If it's 4,000, it's a pretty damn big deal. They're going to feel pretty crappy. All right.
And then the Avadrel is still in a pre-filled syringe
Mhm.
for dose.
It is. It's about 6,500 units. So I'll tell the patient, take half, take a quarter, take a third. And I check the next day. Any Lupron trigger I give, I bring that patient in the next day, and you'll see that I'll check an LH and a beta, just to make sure that they had a surge. If they didn't surge correctly, if their LH is not above 15, I give them an extra dose of HCG to increase my safety net. All right, so let's talk a little bit about IVF cycles. So these are really there are more, there's boutique cycles, right, that I can make up 6 different cycles if I wanted to, using a little bit of this, a little bit of that. In general though, these are the 4 biggest cycles that you'll see run at any IVF center in the country, in the world, right? And the way that they work are all a little bit different. Is everybody kind of familiar with, or people that have been around for a little bit, kind of familiar with the way, the verbiage of these cycles? Right? So the antagonist cycle. All right. So I'm gonna draw this again because I think if you think about the way that we shut this down, it will make way more sense. Now again, we don't really care about the uterus, so I'm going to leave that out for now. All right, an antagonist cycle. Usually what we do for an antagonist cycle, patient calls with their period, and what do?
Bring them in.
I have my period.
Mhm.
I want to start trying it. Say again?
Baseline. Not really.
What do we do with an antagonist cycle? Sorry.
E2
I
prime.
couldn't hear you. I still can't hear you.
Baseline labs.
No. How about, do we start them on pills maybe?
Sure.
Yes. All right, good. All right, so.
Anything you like.
Whatever.
We do 1 to 2 to sometimes 3 weeks of OCPs. What's that doing? Those oral contraceptive pills getting all those cars to the starting line at the same time, right? Getting to the starting line. 2 or 3 weeks later, we stop those pills. They come in for a baseline, and then what do? They have have a low period, they come in for their baseline, we stop the OCPs. We're doing what now? Let's go ahead and start our injections, how about that? All right, so let's start our FSH. So we do our FSH injections, and then we do that FSH injections, so that tells the ovary, hey, start cranking them out, start making follicles. We'll do an ultrasound on cycle day 4, cycle day 6, cycle day 7, and then what do we start right in the middle of that cycle? My antagonist cycle.
Antagon.
Love it, which is what?
Ganirelix.
Ganirelix.
Or
Cetrotide.
cetrotide. It's a GnRH antagonist. So right here, we're going to start the antagonist. Why? Why do we want a GnRH antagonist to block all of...
Stop a premature LH surge.
Boom. So we want to stop the brain, because remember, the brain is like, damn, what's going on here? We're making a lot of follicles. We got a lot of estradiol level. Must be time to ovulate, right? What we want to do is we use that ganirelix or cetrotide, or the antagonist, to block the LH from getting to the anterior pituitary. So it blocks all of the anterior pituitary's release of both FSH and LH. So then, what do we start around the same time as the antagonist?
Menopur.
Yeah,
Menopur.
why?
Because it has a little bit of the
HCG.
It's got a little bit of the HCG that's mimicking what?
the LH.
Why can't it mimic the LH?
Because the beta.
Because they're almost identical, right? So we can use HCG and LH. We can use HCG to mimic a little bit of the LH, right? So now, in this antagonist cycle, we've got Menopur cranking, we've got the FSH cranking. We're making the doses, we're changing the doses based on how the ovaries are acting. When we get the follicles big enough, and the estradiol level is high enough, what do? Yes, we trigger. What do we trigger with? What can we trigger with? Let me ask a better question.
No.
So Folliston, where I've been given, what can we trigger with?
HCG,
Or-
Lupron.
Or Lupron, or both, right? So that's the beauty of this cycle. You can trigger with Lupron, which is going to act just like GnRH, come in. It's going to kick all of the antagonists off of those receptors. It's going to outcompete. It's going to cause an LH surge. It's going to let you ovulate. So you can give Lupron or HCG, or if you're me, both. I like both. So that's the antagonist cycle. We then go on to our retrieval. Dina, you look like you need a
What
question.
is your criteria on starting the Antagon?
Good. So I use, it's not a hard set, but it's more of a 14 millimeter follicle, estradiol level of at least 400 or around stim day 6. Yeah, around. If the patient comes in on stim day 6 and they only have 11s and 12s and their estradiol level is 200, I'll push them another day. I'll tell them to start it the next day. Right. The whole goal of FSH, whether it's Follistim or Gonal-F, is to do what? Make eggs. The whole goal of Menopur is to replace a little bit more of that FSH, but really to give us a little bit of that HCG, which mimics LH, because your antagonist, which is blocking everything, is blocking the release of a little bit of that endogenous LH. And why is LH important? Because it keeps those theca cells making the testosterone, making the androgens that will then ultimately be converted to estrogen. All right, so that is the antagonist cycle. The long luteal Lupron cycle. It's been a while since we've seen that. I have not run one in 2 years here, right? But you guys have seen them, where patient calls with their period. Let's start our cycle. Let's try this again, you three in the front. Patient calls with their period. What do we want to put them on?
Birth control pills.
Excellent. Thank you.
Thank
All
you,
right.
thank you.
So this is antag. Right?
Yeah.
This is the Lupron cycle, the long luteal Lupron. So we're going to start them on OCPs, get all those cars to the starting line at the same time. Once they're on the OCPs, what's the first injection they start taking?
Lupron.
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 Excellent. Good. So they start taking Lupron, right? A pretty high, not a high dose, but a good enough dose of Lupron. And they do that for how many days? About 8 to 10, right? Now wait a minute, Huber, you just said that Lupron was a GnRH agonist. How can that work? Isn't that gonna cause you to ovulate? No. The reason why is because remember, the hypothalamus typically releases in a pulsatile manner. When you give Lupron every day for 8 to 10 days, what it does is it desensitizes and internalizes all of these receptors. So now, you don't have any GnRH receptors at the level of the anterior pituitary. That's how the luteal Lupron cycle, when you give Lupron for 8 to 10 days, then you start your FSH, and you do FSH for 10 or 12 days. You don't need an antagonist here because your Lupron is what's keeping you from ovulating because it's blocked. It's actually internalized all of those receptors at the level of the anterior pituitary. So you will not ovulate while you're still taking Lupron now. Now here's the catch. In this cycle, what can we trigger with?
HCG.
Or,
No Lupron.
huh?
Or Avidro.
All right, so Avidril is HCG, so you can trigger with, this might be a trick question. Just warning you. What can you trigger with? Only HCG.
Yeah.
Why?
Because you already have
Because you're already on
board.
Lupron.
Because your Lupron has already gotten rid of all the receptors where your Lupron trigger would actually hit your anterior pituitary and cause the LH surge. So now, your patient's got an E2 of 4,000, 5,000. Oh shit, right? How are you gonna get out of this one? That's where we started doing cabergoline, albumin, calcium. You know, we started doing all these things trying to get out of the oh shit box because we're locked into an HCG trigger when you are doing a long luteal Lupron. That's why many patients and many folks have moved to the antagonist cycle because our risk of OHSS has gone way, way down with the use of an antagonist cycle.
But these patients could also get letrozole in the end, right?
How good is letrozole at preventing OHSS in luteal Lupron cycles? I don't know the answer to that. I wouldn't put my wife through it. I wouldn't test it on her.
Okay.
So, letrozole again, it might be good, right? But not standard of care.
Okay.
Right. Might be good though. Right.
Some doctors within our practice do that.
I know, that's what I'm saying.
Okay.
So it might be good, I don't know, but there's no level 1 data suggesting that that should be standard of care.
Mhm.
Yeah.
And how
All
long
right.
would you put them on the birth control pills in the beginning? Would it be the same thing, 1, 2, 3 weeks?
Yeah, about 2 or 3 weeks. Yeah. Yeah, like 2 or 3 weeks. So now, microdose Lupron is a little bit different. We're not giving Lupron for 8 to 10 days up front. We're not using birth control pills. We are actually giving a low dose of Lupron every day to do what? To goose the anterior pituitary into releasing, God bless you,
Bless you.
into releasing the patient's own FSH and LH. So we've got a combination of endogenous FSH and LH, and we've got exogenous FSH coming from Folliston. Right, so that's microdose Lupron. Microdose Lupron is different than a long luteal. Microdose Lupron, you do not put them on an antagonist either. So you're kind of walking that fine line of, all right, when are they going to ovulate, when are they going to ovulate? And luckily that microdose Lupron many times keeps them from ovulating. But in general, microdose Lupron is kind of a Hail Mary. Hey, look, this is a heavy duty cycle, let's see if it works. It's kind of the last straw cycles, one of the last straw cycles.
So you just start them after they start their period?
Start the period, you go. Yep, it's a combination of I want to say it's 40 micrograms. I'll have to go back and look at all of that. Maybe it's 10, I forget. Yeah, I think it might be 20 micrograms because we give 4 milligrams when we do a Lupron trigger. It's a fraction of that. Now, the other cycles, so the E2 prime. So what E2 prime means is, all that means is instead of starting pills before in that previous period, we're gonna just give you some estrogen to try and prime the next set of follicles coming along. So the E2 prime, we give estrogen in the period before, and then when you start your period, that's when you start your injectables. I also use Clomid and dexamethasone for a few days throughout that cycle to try and increase a little bit of endogenous FSH and LH that we can get. But E2 priming, you can E2 prime in a microdose Lupron, you can E2 prime in an antagonist cycle, and that's usually what we do. We usually E2 prime and then ultimately use an antagonist to block ovulation. Okay? All right. I'll pause there for a second before I move into, in the last 5 to 10 minutes, we'll talk very quickly about FET cycles. Any questions about IVF stimulation cycles in a nutshell?
Real quick, can you go over the dual cycle?
Yes. It's just taking an E2 prime and doing it twice, right? So what we're looking to do, you do estrogen priming in the period before. You do an antagonist cycle with max dose drugs, right? 300 FSH, 225 FSH, 225 Menopur. You do your retrieval. You then come back 5 days later and you start that cycle right over again.
Okay, well, Dana and I were looking at somebody, I don't know who, and they had some follicles that maybe were in the 20s, but then the other ones were what, 11, 12?
Smaller,
So that was from the first cycle. I mean, that was from the first medication, rather?
The 20s
Yeah.
were probably residual from the last cycle, right? But they were probably with echoes. They probably weren't clear
we can't
cysts.
see that.
Well,
So
it-
you're
it-
saying they're not putting the echoes on there?
What were you looking at? Just the numbers in the
Just
column?
the ultrasound,
Right.
or just the.
But were you reading what the ultrasonographer put in the comments? Did they put anything about
I was
those?
looking on the flow sheet, so it just shows the size of the follicles.
Right. Usually in our duo stems, they'll put, if they have on day 1 of the next stem cycle, they'll put 20, 22, 25, 11, and then in the comments, it'll say that the bigger ones all had echoes, meaning that they're from the last cycle. Yeah, so you can just scratch those. Okay. So a couple different ways to put embryos back, right? One is fresh transfer, one's frozen. The medications that we use for a fresh can vary between institutions. They can certainly vary between docs. Right? For a fresh transfer, for progesterone, you can either use intramuscular or vaginal. The intramuscular is just progesterone and oil, 50 or 100 Q-day. Vaginal progesterone, pretty big variance. You can use endometrin, crenone, or PIO. Right? Pretty good data to suggest in fresh transfers, vaginal progesterone just as good as IM. Estrogen, some docs like oral or vaginal estrogen even in their fresh transfers. Not a bad idea. Doesn't hurt anything. Now frozen transfers, there are a couple different ways to do frozen transfers. One is called an EPFAT, an estrogen programmed frozen embryo transfer. That's where we give estrogen from the very beginning. You can give estrogen whether it's oral, vaginal, you can give estrogen patches, right? And then you can do semi-natural protocol, right? So there's the oral estrase. What estrase is doing is mimicking the first half of our menstrual cycle, which is what? What does it do at the level of the uterus?
Thicken the lining.
Makes it thicker, right? Pretty straightforward. That's what our oral or estrogen patches are doing. It's making that lining thicker. When the lining's thick enough, we can then use IM progesterone. You'd be pretty hard pressed to find an REI that is okay with using vaginal progesterone. Well, there's a couple that will use crenone, but pretty hard pressed to find a doc that would be willing to do an estrogen programmed frozen embryo transfer cycle and then not use injectable IM progesterone. Right, so we all do it here at our practice. Anyone that has done an estrogen program, which I think Dr. Sauter, Dr. Liu, Dr. Clisham, they do a lot of estrogen program, they should be getting IM progesterone, at least 50. sometimes 100 per day. Estrogen patch, same thing. It doesn't really matter how you're getting the estrogen, you're just getting estrogen. But the trick there is with the estrogen program, you're controlling what the endometrium is doing with exogenous hormones. With the semi-natural protocol, right? Semi-natural protocol, we leave the patients alone. We don't give them any estrogen, we don't give them anything. We let them have a natural menstrual cycle. We monitor them with ultrasound and blood work. When they have a follicle that's at least 16 millimeters, their estradiol level's at least 200, and their endometrium is at least 7 millimeters grade A or greater, we'll give them an HCG trigger to make them ovulate that follicle for long-term progesterone. But I'll also give 1 dose of IM progesterone, intramuscular progesterone, to start that clock. Why? Because their progesterone is still pretty low. They haven't ovulated yet, but I want to start that progesterone clock. For what reason? We talked about it a little bit earlier. I'm a 120-hour guy. I'm going to put the embryo back at 120 hours, and the best way to calculate what that 120 hours is going to be is by starting that clock with 1 dose of intramuscular progesterone. Then I'll switch them over to vaginal progesterone, because they're making their own progesterone. They're making their own estrogen. In the semi-natural protocol, we are supplementing progesterone. The patient's making their own progesterone, but we're just boosting them. We're giving them a little bit of a boost, and we can do that vaginally. When we are doing oral estrase, they're not making their own follicle, right? We have blocked the ovary's ability to make an egg. So they're not going to ovulate, hence they're not going to make any progesterone. That's why we want to use intramuscular, because we are replacing, not supplementing. Very big difference. That makes sense? That's why there's a big difference between the estrogen programmed and the semi-natural protocol.
I have a question about that.
Yeah.
So when you give that IM progesterone and that semi-natural,
Mm-hmm.
it's given at a particular time.
Mm-hmm.
Okay.
I'm very particular.
I know, but do you give us the time?
12 a.m., 12 p.m., 11 a.m. I'll write in there. You can give HCG on a Wednesday.
Mm-hmm.
You can give progesterone the same day as HCG. You can give it up to 2 or 3 days later. Because really what you care about is once that patient ovulates, their progesterone level is going to go up. But you know, I just told you, HCG, it's going to take them at least how long before they ovulate?
36 hours.
About 36 hours. Probably going to take more like 48 to 60 for that progesterone to go up high enough that it's going to impact my timing.
Mm-hmm.
So to skip over weekends, you can give HCG and progesterone the same day. You can give the progesterone the next day, or you can give it on that second day, and that will help you time out when you can do your embryo transfer. HCG will make you ovulate. Progesterone, I'll say, progesterone injection, progesterone 50 milligrams IM at noon on Thursday, Friday, Saturday, Sunday, Monday, Tuesday at noon, I'd like to do the transfer.
Mm-hmm.
As long as I'm within an hour plus or minus, I'm okay. Now, if it's an ERA patient, right, I developed that protocol because of ERA. ERA says 85% of patients should be in that 120-hour window. Some are going to be before, some are going to be after. So if I want to do a semi-natural protocol, and ERA says, no, you got to do it on 144 hours. This is a way that I can control that, right? If I start my clock with 1 dose of progesterone IM, and then the next day they start endometrium to keep that up. I know that if I need 144 hours, if I give it at noon on a Thursday, Friday, Saturday, Sunday, Monday, Tuesday, Wednesday at noon, that's going to be 144 hours of progesterone exposure. Cool?
And what is that biopsy, the ERA, is it endometrial biopsy, and what are they looking at to time?
It's like 266 genes that are associated with, they're either upregulated or downregulated, and it's a big data set that they run comparatively. They run to see if that biopsy that you sent them, whenever it was taken, at X amount of hours of progesterone, are you in the window of implantation, the window of receptivity. It will tell you, yep, do your embryo biopsy or do your embryo transfer there. or it'll tell you go 12 hours earlier, it'll tell you go 12 hours later, or sometimes it'll say, whoa, this is way out of there. You gotta do that biopsy 24 hours earlier because we have no idea where you are.
So it's almost like, it's like a cycle before you're actually.
It's gotta be, yeah, it's a mock cycle.
Good question. Why doesn't everybody get an ERA biopsy?
Excellent question. It's all about the number needed to treat, right? Your test is only as good as the population that you do it in. So this is actually a discussion that I had when I was defending my case list on my REI oral boards. One of the examiners asked me, why'd you do an ERA biopsy in this patient? She had an M transfer. I said, well, the patient walked in, she was a healthcare provider, and she says, I want this test. Well, who do you do it in? Well, I don't do it in everyone because I would have to do somewhere in the neighborhood of 20, 30, maybe even 40 biopsies in patients to find one patient that would actually clinically benefit from us moving off that 120-hour window. Have y'all ever had an endometrial biopsy?
I think so.
How fun are they?
Not.
Right.
Not.
So,
Not.
I mean, if it was my wife, which I treat, like when I'm taking care of my patients, I think about what would I do if it was my wife? I don't, the cohort of, if I did an endometrial biopsy, an ERA on every single patient that came through here, and then we looked globally at whether or not we thought ERA made a difference, the answer would probably be no. If then you take all patients who have had a euploid embryo transfer that did not stick, and then you test them, the positive predictive value of that test is going to go up, right? So instead of needing to do 40 biopsies, now I need to do 12, right? And I can live with that. Right? I'd like to think that I can go in, do a biopsy pretty quick, get out, and patients do fine. But when a euploid embryo should be sticking about 65 to 70% of the time, if it doesn't stick, that's one of the main reasons why I think that we should do the ERA. But I do not do it on every single patient. I don't recommend that either. Good question.
Okay, so it's oral, estrace, or the vaginal, and then the patches, and sometimes they're doing injectable.
Let me back up a step. So the oral, there's a couple of different ways to do it. So you can do oral estrace, you do 2 milligrams PO twice a day for like 8 days, mimic your physiological menstrual cycle. After 8 to 10 days, then you bump it up to TID. Then you come in for your ultrasound. If your endometrium looks good, let's go ahead and start them on progesterone. There are other protocols where you can use patches, Bival patches. There are other protocols where you can use ethinyl estradiol, where you're actually given injections like every 3rd day. So there's multiple different ways. The bottom line is you're using exogenous estrogen to block ovulation and then to thicken the lining with exogenous estrogen.
And why would you do one as opposed to the other?
It's the way you train, it's the way you think is best for your patients. Sometimes patients do better with transdermal because what happens when you take any pill? Where does it go first? No, where does it go first?
Oh, GI.
Tell me a little bit more.
So.
Where does it go? It goes through your belly, it goes through your stomach, and then it goes to what organ first? And what does the liver do to everything? Metabolizes it, chooses it up every which way to Sunday. So which way do you think, how much estrogen do you think, how much estradiol do you think actually gets down to the level of the endometrium after it gets banged around by the liver? Not that much, right? So that's why we got to give such a high dose. Well, an estrogen in most people is very safe, but in other patients, it goes to the liver, and what else does it do at the level of the liver? It increases your clotting factors, and if you're a smoker, it increases your risk of clots, right? So, I like to do no harm. Transdermal, though, does transdermal go through the liver?
No.
Not first, right? It goes right to the organ. So that's a whole another talk. Maybe we'll talk about postmenopausal hormone replacement therapy next. Transdermal.
Yeah.
Yeah.
Samples, can I have samples?
You might get along better with your nurses if you
Right.
Along with Botox.
took
That's
care of
right.
that.
Botox!
I would have been a guinea
We'll
pig.
pass the hat
I've been trying
for Botox training. I'm not paying for that. Y'all can pay for me to go, but I'm not paying to go to
It only takes
Botox
like
training.
200.
Any questions?
Girl,
Thank
we'll
you
all
for coming.
pay her.
Do you have any questions about anything?
No, I think I'm good, thank you. Just trying to absorb everything.
Yeah, it's a lot to absorb. I think I went to school for 17 years after college, so it takes some time. Right. Any questions about any of that? So let's just recap real quick. We talked about the menstrual cycle and how the brain, the ovary, or different parts of the brain, different parts of the ovary will work to tell the uterus what to do. If we get a pregnancy, the HCG rescues that corpus luteum, our progesterone stays alive and well. If we don't get it, that's when we have a period. We have different oral ovulation induction medications. We use those to impact that discussion between the brain and the ovary. One of them's a trickster. One of them actually makes you hypoestrogenic. The brain compensates by sending more hormone down to the level of the ovary, because the bottom line is the ovary is what is going to change that hormonal milieu, whether it's estrogen or progesterone. The other thing we talked about was injectable medications. Remember, all we're doing with those injectable medications is impacting this discussion. So let me leave you with this one metaphor. Women are born with all of their eggs, right? They're born with every single one of them. Sperm, as I've stood up here, I've probably made 1 million sperm. But eggs, they continue to go away, right? Men, they continue to make sperm even into the 40s, 50s, 60s. The way I describe it to patients is the ovary, think about it as the superdome, right? The ovary is the superdome. The superdome is the ovary. You're born with 1 million people in your superdome. At puberty, you're down to 500,000. They're all seated in the different sections. When you start your period, every month somebody walks into the superdome and says, all right, section 122, come on out to the ramp. That section, everybody stands up, they walk out to the ramp, everybody else stays in the superdome, it's not their turn. They come out, they have a competition. That one person that wins that competition gets to ovulate. What happens to the people on the ramp that didn't win that competition?
They go
They
away.
go home. They
They
don't
go
go back in the dome,
Nope.
right? The next month she walks in, she says, all right, section 235, your turn, come on out. They have that competition, right? So what are we doing with when we work patients up? We're using things like AMH, cycle day 3 antral follicle count, and things like FSH and estradiol level to tell me, number one, how many people are still left in the dome? Number two, how many people are seated in each section in that dome? Number three, how many people are coming out to that ramp in that particular section to work so that we can work on that cycle? We then use medications, so we use oral medications to help that conductor get those people out of the dome onto the ramp. Some of the medications help the conductor start the competition. Some of the medications help that competition along, and instead of only having one winner, we want everybody to win. Right? So that's what IVF does. It doesn't mess with the rest of the eggs or the rest of the people in the superdome. It's all about getting them out to the ramp. And the oral ovulation induction medications, we try and get 1, 2, maybe 3 or 4 people to win that competition. In IVF cycle, we try and get everybody to win. Everybody wins. We go and pick them up. We take them, we put them in the lab, right, before they can ovulate. But we didn't mess around with the rest of the people in the dome. So that's why every single cycle that we do, it's a different section that comes out to that ramp. And we're just using our medications to impact that competition.
The ramp being
Where the bands play, where like you can sit before you go in the dome.
in the body.
I'm sorry, what?
The ramp, like you're bringing them out.
You
so
bring
you're-
them out of the superdome,
Right.
and that's your antral follicle count.
So what part
right?
of
The ones-
the woman's body is the ramp?
The ramp is the cortex of the ovary where you're starting. So you have this large follicular pool inside the ovary.
That's my question.
The people that come out of the superdome onto the ramp
Yeah.
are only that cohort of eggs that are going to compete to become the one dominant follicle that month, that particular month. If you want like coordinates in the ovary, I can't give you that. I don't know the answer to that.
Well, then,
Just go with the metaphor, Mom. It's,
I just.
it's, no, I get it. I don't know the whole, I don't know the specific part of the ovary, but it's, yeah, cortex to,
Gotcha.
yeah.
Okay, so if we're talking about that, and we have these antral follicles coming out, and we do our baseline ultrasound in lab, and let's say we have a cyst on our ovary, why don't I give drugs on top of that cyst?
So be a little bit more specific about the cyst, right? So
It's not a cyst that's well,
What do we
it's,
check? If you have a cyst on the ovary, it's my
Estradiol.
first
we
question.
check an
My
estradiol.
first question is, what's her E2? Right?
It's
What's her
50.
50. So does that sound like a functional cyst to you?
No,
No.
Then I pretend like it's not even there.
so you just keep moving.
Just move. If it's 150, then what happened? Somebody started the competition before everybody else was ready,
Mhm.
right? They ran to the ramp before they were called.
Okay,
So then what do
so,
we say? Well, let's put them on pills, quiet everybody down, get everybody back
Mhm.
in their seats,
Mhm.
and then we'll start the competition over again.
okay, so this is what, it's for my new nurses that are gonna be starting. So, hello. So if I start meds on top of that cyst, that is now we've figured out it is a
I don't
cyst.
like the word cyst.
Okay,
I don't like
well,
the word
I have a follicle that
cyst.
started in
Do you want
advance.
to call it a follicular cyst, or you want to call it a simple cyst?
I wanna call it a simple cyst.
Love it. Simple cyst means I don't care about it.
Okay, but if I start meds, what happens to it?
I don't care. I don't know.
If it is producing estrogen, right?
I mean,
Yeah.
well, but if it's, if you
If
start.
it's already producing.
If it's
you
already
started-
started off, what happens if I start meds? Is it, are the
gonna get bigger.
follicles
I mean,
below
The
going to
follicles
grow?
below, depends on how much the FSH depends. Let's go back to that other slide. It depends on.
Bad question.
So remember, it's not just FSH and LH. I tried to keep it simple. You have other things called inhibins, follistatin. You have a few other things. See how later. Activin, inhibin, follistatin. There are other factors at play here. So chances are you probably would not have additional follicles following it up because that dominant follicle has already sent everybody else home.
That's what I wanna know.
I think.
Okay.
I think. Don't mean no comment. I think every other patient, every patient could be different, right?
Okay.
Yeah. Every patient can be different.
Okay.
But likely you're not gonna get the cohort you want. It's gonna stimulate the one that's already
Your-
out
your-
on deck.
Your cohort on the ramp has already been tainted.
Right.
So what Dr. Liu explained to me years ago was that one cyst, or simple cyst, whatever you wanna call it, basically becomes the bully and doesn't let any of the other eggs
If it's
or
functional. I
follicles
agree with that. If it's functional.
come up. No matter whether you give it meds or not, it's not gonna
If it's
work.
functional, that's 100% correct.
Okay.
Because it's sending out all these other killer factors, right? Now, you may have that one or two patients that their brain
Correct.
sends enough FSH to recruit another follicle, and dude, now you're really out of whack. Because they're gonna have a cycle, then they're gonna ovulate, they're gonna have a period 2 weeks later. It's another good point. How long is a typical menstrual cycle?
28 days.
28 days, right? All right, so if I tell you a menstrual cycle is 28 days, how long is each phase? Follicular phase where we're making a follicle is what, 14 days?
14,
Luteal phase after you ovulated that follicle is what?
14.
Excellent, 28 minus 14. If I told you my menstrual cycle is 35 days, how long would you tell me my follicular phase is? Think about it and touch
21,
that. Okay, why?
because you start a period 14 days after you ovulate.
The most consistent portion of the menstrual cycle is the luteal phase. After you ovulate, should be between 13 and 15 days. If you're not pregnant, you're gonna have a period. How do you know that you didn't ovulate? You don't have a period. All right, or we can check a progesterone. If it's less than 3, it's consistent with no ovulation. So you'll see when patients call at cycle day 32, 34, what do? I'll bring them in, I'll check a beta. Otherwise you'll fail your oral boards. You check a beta first, check a pregnancy test. Some of them pop up positive. And I check a progesterone. If the progesterone is 4, 5, 6, 20, I'll say you're gonna have a period within a week or two. Call us. If the progesterone is 0.2,
They didn't
it can be one or
ovulate.
two things. They either ovulated and they're going to have a period like that day or the next, or they didn't ovulate. So I'll give them a few more days if it's low. If it's low and negative, I'll say go ahead and start Prometrium or progesterone, Provera. Because what's the worst thing that can happen? They start Provera, oops, I'm pregnant. It's okay, it's progesterone. It's good for a pregnancy. Or they end up having a period a day later, you say, all right, stop your Provera. It's not going to hurt anything. Good. I feel like I'm being watched here.
You are, wave.
What about a luteal phase defect?
Debatable, right? In the literature, there was a nice article, recent FNS, the mystery of the luteal phase defect, whether or not it's truly a phenomenon where that corpus luteum, right, where we ovulated from, its job is to make that progesterone. And if for any reason, if that corpus luteum decides, you know what, I'm out a little bit earlier than it should be, that HCG doesn't have time to rescue it, or maybe it's not rescuable, and then you might have an embryo in the uterine cavity, but guess what? You've lost your progestational hormone, you slough off that endometrium, no pregnancy. Right? There are some very strong believers of that tenet, and there are some that don't believe it at all. I believe it because what's the harm in starting a little progesterone? Not much. Will it benefit all? Probably not. Will it benefit some? Probably. My opinion. Yeah.
There's another med that I know is used sometimes, I'm not sure, the bromocriptine, I don't know the function of it.
It's cabergoline. It's very similar to cabergoline. It's a dopamine agonist. So what it does is it blocks the release of VEGF. Yeah, Parladel, yes. So VEGF, or vascular endothelial growth factor, is released from the ovary, and that makes all of your capillaries very leaky, and that's where you start to third space a lot of your fluid. That's why you get a lot of fluid in your belly. That's why you get dehydrated. And we think that cabergoline and bromocriptine are two medications that have started before the trigger, can reduce the overall level of VEGF that's released, and it can reduce the leaky capillaries. Cabergoline, yeah.
Haley, are you talking about bromocriptine, like when they're taking it like twice a week?
As when?
Are you talking about when they're taking it like twice a week,
Yeah.
or?
Oh, I thought you meant like for
That's for
OHSS.
No, that's for, it's for prolactin levels, high prolactin levels.
Yeah, you can use it. You can also use it. Why can you use it for high prolactin levels, do you?
You're about to tell us.
You're about to tell us. Go ahead.
They used to
So what's
give
that?
it like with, to dry up the breast milk.
Right. So
Used
why?
to.
Used to.
Why?
Because
Shuts down
You might
the.
know the physiological function of that. Prolactin is under tonic inhibition by dopamine. So if you give a dopamine antagonist, right, that will block that tonic inhibition, and your prolactin levels will go up. Other way around. If you give a dopamine agonist, it will block your prolactin. So that's why you give cabergoline and bromocriptine. It's a dopamine agonist that helps with the inhibition of prolactin release from the anterior pituitary. And we also go looking for prolactinomas, right? We'll do MRIs of the brain looking for the little prolactinoma. The reason why is large majority of those little prolactinomas are benign. You just leave them alone, watch them. But occasionally you'll pick up a macro prolactinoma. And those in pregnancy can get bigger, and that anterior pituitary sits right on top of that optic chiasm. So one of the complaints that you have in a pregnant patient that their prolactinoma has gotten bigger is that they'll have something called bilateral temporal hemianopsia, where they can't see peripheral. So walked out and I got hit by a car because I can't see. That's right.
Does it decrease after the pregnancy?
Well, you treat it with an agonist, but sometimes you have to go and get a transsphenoidal resection, and neurosurgeons jump at that surgery.
Okay.
They love that surgery. So don't send a prolactinoma to a neurosurgeon unless you expect them to get a transsphenoidal resection. You can bank on it. Anything else? Any other meds that we missed? Good question. Was this helpful?
Yes.
Yes.
Good.
Yes.
Good. Well, happy to do it again.
Yeah.
If need be.
Thank you.
All right, you're welcome.
Thank you.